Thank you again. And thank you. This talk was originally supposed to be delivered by Dr. Mangat Dogra, who could not be here for personal reasons. So this talk is heavily borrowed also from his experience and from the experience of a friend, which I'll be sharing shortly. So this is wide field retinal imaging. A lot of it is going to concentrate on adult, and then I'll add some pediatric wide field imaging experience as well. I have no financial interest to disclose. So the adult retinal images that you will be seeing now are courtesy Dr. Mangat Dogra from PGI. So the Optos is a device nowadays that I think few centers in India have, and there's a limited amount of collected published literature on it. It's about a 200-degree field and promises to give you good images even in a non-mydriatic format. Primarily, it was meant for anterior segment surgeons to have in their clinic to possibly use as a screening device for retinal pathologies, especially in the periphery, retinal breaks, lattice degenerations, maybe for a LASIK surgeon to have sort of a pre-workup before he does a LASIK because he doesn't have access to a VR surgeon. But that's how it was being marketed initially. But of late, its use clinically and its relevance in terms of predicting diseases that even we've been managing day in and day out has borne some advantages. So let's look at some of these. These are examples from Dr. Dogra's collection. So a regular retinal detachment, where we all know how sometimes difficult it is to pick up small breaks, and when we are happy picking up one, we tend to miss another. So just imaging 200 degrees field, even in the mydriatic format, would be something useful. Monitoring these patients after surgery, be it a gas bubble or an oil bubble, for the amount of fill and the way the retina is reattaching, for doing supplement laser or even buccal revision after surgery is another completely different indication. Coates disease, when it occurs in the center, is so easy to pick up. There's subretinal exudation and there's some amount of telangiectasias. But peripheral changes sometimes are missed. Even on routine standard fundus photography with ETDRS like protocols, they are missed. Retinal arteriovenous AV malformations here in this case, and then converting that into an angiogram, shows you exactly where the capillary non-perfusion lies. And this is useful if you want to do the laser, when you can look at its completion. You can see where the laser should have been and where you have given it, and the adequacy of your treatment, and then monitoring it. This is done with the Pascal, and you can monitor these patients with peripheral vascular dropout diseases. And we know so many conditions that we manage both in retina and in uvea have peripheral vascular problems, just like IRVAN. So the neuroretinitis, the aneurysm, the retinitis, the vasculitis, all these components are better picked up, especially when they happen in the periphery. A CMV retinitis in this case is an active lesion here, which you're actually monitoring. And remember, this can be done even in the non-mydriatic format. You're monitoring both the progression of the disease or its response to therapy. Lymphomas, which sometimes come out as masquerades, they come out as both vitreous and retinal elements, choroidal as well. And if you're able to image them in the periphery with a single field, then it's helpful. An example of a peripheral vasculitic problem, an occlusive vasculitis like in Bechet's disease, is again very easily monitored. Now to move on to some pediatric retina optos. To tell you very frankly, we had the demo device at our institute in Bangalore, but we just couldn't get baby to stand up. Even though we've done OCT on babies in the the flying eye position, as they called it, somehow we were not able to get these babies to get for acute ROP screening. But Daraj Shroff is here in the audience, and he's been kind enough to share his experience. So he took a cue from the Patel group in Oxford, who actually coined the term flying baby way back in 1995, when they used time domain OCT to sort of keep a baby supine or hold it up, hyperextended neck, as you will. So that's Dr. Patel and his images of retinopathy of prematurity. And this is back home in Delhi in the Raisis Center. So the key he'll tell you is not really to use the chin lift, the chin rest, which the adults will use, but actually to prop the baby yourself, for which you have to sort of swaddle the baby very well and hold it in a vertical position. So some of the cases that he's had and he's shared. So this one, we all know after retinopathy of prematurity laser, it's good to monitor these patients for the adequacy of the treatment. So this is about 4 weeks post-treatment things are looking quite good in some areas, and in some areas you still begin to see a sort of a regression, but a part of it is still active ridge here and some amount of tortuosity. So this helps you better plan supplement treatment, whether it's in the form of laser or any other. And this eye still not doing as well as he would like to, so he's monitoring the peripheral changes to see where he needs to intervene. Familial exudative vitreoretinopathy is probably going to be one place, and if you look at Mike Treacy's publications on this, he says the way he manages FEVR has completely changed after wide field imaging. And the reason for this is all these FEVR changes are in the periphery, and monitoring these patients is important because we don't laser all FEVR babies. We would laser them only when they turn, when they have neovascularization or when they bleed. And one doesn't really know which babies progress and which remain stationary. And some of these are monitored for life. So imagine you have this could be an 8-year-old who will cooperate on the optos just like an adult. But to have a biannual or an annual visit where you're just monitoring the peripheral changes is something that's going to be a game changer. Also, when you look at the studies in diabetic retinopathy, the ILEO study in ophthalmology about 2 years ago has shown that peripheral retinopathy changes are now happening even before central diabetic changes. And I think this would be important when you're looking at a disease progression point of view, because peripheral changes are not going to affect vision, but you're now at a position of not just imaging them, but even mapping them, and I'll share some of that experience. And then you can predict that, oh, you have these peripheral changes, so you are at this much higher risk of developing central changes, and that could mean a lot to our patients. Another case of familial exudative vitreoretinopathy with avascular periphery, and we know that in FEVR, the peripheries never vascularize, but unlike ROP, that after treatment, the blood vessels do reach the end, and an angiography will tell you that, and it will also tell you the adequacy of the treatment. And this clearly shows you the NV that's leaking and the avascularity in the periphery. So our experience has been a joint project that we are doing with the Doheny. We had the optos for a little while, and we have just over about 350 diabetic patients, which we are doing with an image processing study, where, as I mentioned, we are looking at changes in the periphery to predict prospectively these patients for diabetic retinopathy. And there are different arms of these studies. Some of them are treatment naive, and some of them have been treated. Now, you will agree that you're looking at scattered laser, you'll see some hard exudates in the center, there's some stuff going on. But what's important is to map these, or rather to annotate these. So you see these red polygons that show up. I'll quickly move these photos. Oh, I'm sorry. So you will see the change in the annotations. Now, wide field imaging gives you the ability to annotate all these changes in one field, which is way more advantageous than doing it in the standard ETDRS7 field. And this is important from clinical studies perspective. With more and more emphasis on peripheral changes, predicting central changes, possibly the future of how we're going to both monitor these patients and treat them is going to be through wide field imaging. Of course, this technology is being limited with the resolution and the speed of acquisition of these images, but nevertheless. So here are some annotations of the hard exudates done with a separate color and the hemorrhage is done with a separate color. And again, important from a clinical study point of view. This otherwise normal looking central macula has hard exudates, which we've annotated here, and then of course these peripheral changes which may have been missed if you just take a posterior pole image. Otherwise heavily lasered eye, that's been annotated as well, and a similar case here with the small hard exudates, soft exudates, and aneurysms as well. So ultra wide field angiography is the ability to take, you saw some of these examples, but just to give you a field perspective, from 30 degrees, a normal standard fundus camera will give you 45 degrees, but this optos gives you up to 200. So to look at the so-called Eales disease or peripheral retinal vasculitis or these peripheral changes or FEVR, it's really a good thing. Now, these diabetic changes that happen in the periphery, these are the ILEO studies that I was talking about, are the ones that are now predicting central changes happening after peripheral changes. But now this throws up a new Pandora's box. So now we are imaging conditions that we didn't see or do before. Just like Dr. Vishali showed you how the FAZ is no longer possibly avascular, because now we are looking at small vessels traverse that region. You are now looking at peripheral pathologies when otherwise normal looking fundi. So how do we make this in a perspective of are these normal variants, are these physiological normal variants? So this study looks at wide field angiography in patients without any peripheral disease, the so-called study of normal peripheral findings, and finds a whole lot of problems, including vascular dropouts and early NVE like Franz and IRMA like abilities and RP dropouts. Are these patients more prone to retinal holes, retinal detachments? Do they have any appearance on what they had before in terms of pathology? These are, of course, questions that we need to answer in the future. I have some very limited experience on OCT angiography on a baby. We've just got this accepted. So this is an attempt at looking at the deeper structures of the neovascularization using the OCT angiography. Dr. Vishali showed you so well that the difference between a collateral and a neovascularization and an NVE look beyond just what's happening on the level, look underneath. So this is what we really were interested in. This is a decently lasered aggressive posterior ROP which started. We know we need more supplement. We know some hemorrhage is going on, but when it recurs and then you get this sort of an arm coming in, you have to go back and supplement. And somewhere hidden here is a neovascularization. A few years ago, we had shown this in our previous publication using the Heidelberg spectralis, which we dismantled, and we took an image of the NVE and lasered selectively that NVE and showed on a repeat scan that NVE went away. What we were interested in now was, can we map the deeper aspects of the NVE? Because in AP-ROP, we only talk about flat neovascularization, and we don't really believe there's anything going on underneath. She also showed you a picture of an NVD, which on standard angiography will leak. And when it leaks, it obscures all the detail that's happening underneath the NVD. But with an OCT angiography, you're able to see it very clearly. You're able to delineate that almost a tubular fashion, and now see not just the extent of the NVD, but its depth as well. So here was our attempt. So this was the standard aggressive posterior ROP, and still the avascularity that remains, and then the NV, and this is actually post-treatment. But before that, let's look at what the OCT angiography showed. This was in a similar manner, holding up the baby vertical. You can call it beginner's luck, but we are doing this on more babies now. So this is the OCT that comes out of the device itself, and these are the NVE complexes, which have subtle strands on the pre-retinal area. And you look at these complexes here exactly corresponding to this, the superficial retinal level. This is the deeper retina, this is the outer retina, and this is the choriocapillary layer. Now we know, and as she's shown you, that the deeper retina is not supposed to have any of these white lesions. These are not called fluorescent lesions because there is no fluorescence. So let's call them white lesions or flow lesions. That's what it's better described as. So what we went ahead and showed here was that the NV is not just superficial but has deeper extensions. And these are not artifacts. This one is. This one's called a fill-in artifact, and this happens because of the shadow of the superficial layers that go down. And to prove this to ourselves, we had to resegment these images. But then the proof really came when we selectively treated these NVEs, and 10 days later the NVE went away. And you can see the superficial network now straightening out. So no more those multiple complexes. But what was amazing was that the deeper complexes had completely gone. So we believe now that the NVE that we spoke of in ROP, which was supposed to be flat and only overlying the retina, actually is now a deeper complex. So we are proposing that the terminology not NVE but the NVC, or a neovascular complex, be used. I'm going to end with a clinical trial that we are doing with the Department of Biotechnology and a Bangalore-based company called Forest Health. You'll have possibly seen or used its adult camera called the Forest Trinetra Royal. They got interested in making a low-cost RetCam, which is going to be an infant imaging device. We've been fortunate to test that. So here are some of it, images while we're doing it in the NICU. So this is a fusiform camera. Unlike the RetCam, it does not require that you detach and attach these different lenses. It has a liquid lens that keeps changing, internally of course. It has a 120-degree field, compares just to the RetCam. The foot switch is just like the RetCam, and it's more portable. It's about 340 degrees light. The RetCam is about 580, depending on which lens you've attached to it, and so on. We crop these images. Now, if you've seen standard RetCam images, this is what they look like. They have a cropped top and a below, but the Neo produces a complete circle. So if we had to mask these images, we had to crop them to make them look similar. So this is an ongoing trial, and we're doing it in different rural areas in Karnataka. Let me just quickly share with you the results. So the sensitivities are good, the specificities still need some improvement. In terms of technology, it's modest. It has a CMOS sensor, unlike the RetCam, which has a CCD, so the resolution is not quite as good as the RetCam, but it's certainly serving as a good screening device. Now, is it a good staging device? That's something the research trial will show. Now, I don't know how many of you all can guess which one is from the RetCam and which one's from the Neo. Let me just tell you that the lower panel horizontal is the RetCam. You're seeing an early stage 2 in zone 3, which is a peripheral an image. Until now, you didn't have any other device that did this, and here it is on the Neo. This one shows you the avascular periphery in an immature retina without any disease. So this vertical panel here is the Neo, and this one's the horizontal. Let's look at some raw images. This is the RetCam, and you can just about see there's some popcorn lesion and probably some early disease. And then the same eye, same baby, it actually gets a slightly wider view here, and you're able to pick up the pathology. This is on RetCam, stage 2 and zone 3, a similar picture on the Neo. So you can see that you're picking up the disease, but the resolution is not quite there, but probably good enough as a screening tool. Anand? This is on the RetCam, an early stage 3, parts of it, of course, stage 2 in zone 2 anterior, and the same one on Neo. So I have no financial interest in this, but we've been able to help to validate that, and this paper's got accepted for the forthcoming ARVO. Thank you very much. Okay.